Top Med Talk.
Good morning and welcome to the latest in our series, Fluid Matters. I'm Desiree Chappell, host of Top Med Talk, and I'm joined here with Monty Mythen, Editor-in-Chief. Good morning, Monty.
Morning, Desiree. How are you?
I'm great, thank you. And Henry Howe of Top Med Talk. And we are this weekend at the Perioperative Quality Initiative at the Washington Duke down here in Durham. And we have been talking about everything involving fluids. Specifically, we have a couple groups this weekend that we are doing a deep dive into, first of all, intravascular volume and fluid responsiveness. And Group B is talking about total body water and electrolytes. So some pretty heavy topics that we have discussed all day yesterday and going to wrap up today and kind of hopefully come up with some consensus statements and guidelines, recommendations for clinical use and practical use in a clinical setting. So, Monty, I was in Group A, and you're in Group B. And so we spent a lot of the day breaking out into our groups and having these discussions about our specific topics. And then we came together as the large group and shared some of our findings and ideas. And so I was just kind of wanting to get your take on that.
Well, I'd say the good news is, considering the level of expertise in the room, some extremely well-known names in this field, is how much people agree on. So that's good news. So there'll be considerable clarity on many of the big picture items about what we think fluid responsiveness is, how one might be able to determine it. But then there are still some controversial issues. There are still, and maybe the controversy is more about names, titles, and definitions than it is about the clinical utility and relevance of these things. And I think one thing that's been stressing us all is stressed volume or unstressed volume.
Lots of discussion around that yesterday.
So we've only heard, myself and Henry have only heard the public discussions. And Henry, what do you think? We still got a bit of way to go on that?
Definitely, there was a lot of debate and talk about stress volumes yesterday. It'd be interesting to hear from Desiree.
Yeah.
How Group A was diving into it, really.
Yeah, it was kind of split down the middle between the intensivist and, post-op side.
Okay, so they didn't go into, what do they think it is?
Well, that's a great question.
The clinical relevant bit, as far as I've understood from and it's not a term we use very, very commonly in the UK. It's in the books. You hear it quite often referred to in the USA. But in the UK, we don't tend to talk as much about it. What we recognise is the fact is that there's a lot of intravascular volume in the venous capacitance vessels, and a lot of it's not necessarily doing a job here and now, and therefore you can bring into play some of that fluid if you need to. But I'm not sure where the stressed bit comes in or the unstressed bit. Henry, you're young and bright. What did you take away from the whole thing?
To be honest, it gave a lot of mixed messages, because I thought that although we got a lot of consensus in the room, on this particular topic, defining stress volume seemed to be the hardest bit. I'm not too sure as to how I would define it after listening in.
It's the old thing about it's a bit like an elephant.
Yeah.
We all know what we're talking about here, but they're quite hard to describe.
Yeah,
so maybe we just need to move on from that and talk about the clinical relevance of the whole thing. And any clinical relevance that if you could get them to stop talking about the definitions, any clarity yet on the clinical I think it'll come today, but...
Yeah, again, we didn't actually come to a consensus at the end and determine really how we use that clinically. I mean, we talked a lot about the venous, being on the venous side and having the volumes, and you have to fill it up. And there were a couple good examples of what a stressed volume looked like.
So there's people listening at home who know the definitions of stressed and unstressed volume who are thinking, you bozos, what are you doing in that room as alleged experts when you don't know the difference between the two? But the point is that it appears to mean different things to different people. And I think the same thing happened when we discussed preload. Yeah. So I believe at one stage people decided to look up preload and they found 32 different definitions on the first attempt. I mean... So to me, preload, when I think of it conceptually, I think about left ventricular end diastolic volume.
Yeah.
So the amount of stretch in the fibres on the left side of the heart at the end of diastole, which determines the force with which that volume will be ejected from the heart. But apparently it doesn't mean that to some people. It means different things. So again, it's one of those things where I think they're going to have to come with some language where when we talk about it, we all know we're talking about the same thing.
Yeah, I mean, that, again, a highly debated subject whenever we were in there. And I think as a consensus, we came up with kind of the left ventricular and diastolic volume and the stretch. But we feel like the terminology is a little misleading whenever you talk about kind of the recruitable stroke volume in response to fluid. And there was some discussion about, do we call it fluid responsiveness or do we call it preload responsiveness?
Well, volume responsiveness is the new discussion, I think, from last night.
It is, yeah. So again, it was easy to get into the weeds when we were discussing terminology and defining these different all the different verbiage that we've used in practice all the time, but means different things to different people. Another topic that we talked about for a long time was, do we use hypovolemia, hypervolemia, absolute, versus relative, and what terms are we going to land on to express what we're trying to when it comes to fluid responsiveness? Intravascular volume was another one.
And I think, again, those terms are used by different people in different ways and to mean different things. One of the things we were referring to, it's back to the old hydration story as well. You can be hypervolemic if that means you've got too much fluid in the intravascular space, and or it means you've got a high total body water. If you have a high total body water and a high total body salt, you can be thirsty, and if you are thirsty because your osmoles are elevated, does that mean you're dehydrated? And if that's difficult for 20 or 30 of the world's alleged top experts in this field, it's going to be damn difficult for a second-year medical student.
Or someone at the bedside trying to decide.
Trying to do the work.
Yeah.
The nurses are doing all the work in reality, aren't they? So and the junior doctors are doing all the prescribing, so they're the ones who've got to get it.
Yeah.
Maybe we should explain it to the patient. Maybe that would be...
Maybe then they can turn around and...
They'd say, come on, guys, you're making this way too complicated. I'm thirsty.
Can I have a drink of water, please? Yeah. Well, I mean, again, trying to disseminate or trying to filter all of that out and then get to what really matters and how we're going to clarify in the statements, and how that can make a difference practically. The total body water thing, I mean, you guys talked a lot about that and electrolytes in group.
Yeah, we nailed it.
Yeah, how'd that go?
Yeah, we're certain. We're crystal clear. Agreed, Henry?
Crystal clear.
I saw some great slides. You guys are obviously distilled something down there.
Well, I think the good news, because, there's been a lot of talk in recent years about Starling's forces, the balance between, in this situation, Starling did a lot of stuff. To be fair, the discussions about left ventricular end diastolic volume are linked back to Ernest Henry Starling as well. But in this situation, our Starling forces we're discussing is the determinants of fluid leaving the blood vessels and the balance between pressure, transcapillary pressure, and oncotic pressure, pressure generated by proteins or larger molecules in the bloodstream. Everything that doesn't escape there creates or contributes to oncotic pressure, but we tend to think of it in terms of things like albumin. And the good news is that we've agreed that they still are in play. There's a few extra nuances in there. There's these glycocalyx, of which I'll come back to that in a second, because we found a new one recently, apparently. And there's some other definitions, but from the point of view of stuff escaping from the vessel, it seems as though what I was taught, and I'm guessing you were taught, Desiree, and I'm guessing you were taught, Henry, we'll get to comment in a second, appears to hold. So that bit, that's good news, because I thought, man, I can't live my whole life. And one of the few,
I've been living a lie.
One of the few things I could get my head around turns out to be wrong. Henry, reassuring?
Yeah, the hydrostatic and oncotic pressures that we taught stay in place, which is great. The whole concept of how the Starling pressures work is all in place. But what was really interesting for me is we're taught how you can leave out of the capillaries. You get filtered on the left-hand side of the diagram, if you can picture it. But then we're always taught that there's slight a reabsorption on the right-hand side. Whereas actually now, from the consensus yesterday, this process doesn't happen unless in extreme and in some certain conditions.
That was the power moment, wasn't it?
That was the power moment.
So if everyone's visualising now that, I mean, I've put it in numerous articles, textbooks, shown slides, as we all have. We show a single pipe, and we have the A end and the V end, and stuff is predominantly because the pressure's higher than the suck at the A end goes out, and at the V end, the venous end, the suck is higher than the pressure, so it comes back in. But the oh no moment was apparently that don't happen.
Yeah.
Is that, Desiree, is that what you heard?
That was the takeaway for me.
No, I'm not sure what I'm going to do about that at the bedside, but we will loop back on that. But apparently, if fluid filtered in a vessel, with very, very few exceptions, does not reabsorb in that vessel.
Yeah. So what were they talking about? Where does it go?
The big player in all of this is what, Henry? Where's it all go?
Lymph. Lymph is the big key player, and that's why there was a lot of emphasis yesterday on the importance of lymph.
Lymph is the word.
Yeah, important when we're talking about treating patients with fluids and how it can affect.
So because I mean I've been aware of the lymph. We're all aware of the lymphatics, but considering the amount of time we've spent and been taught about the arterial side of the circulation and a bit of tokenism to the venous side of the circulation, kind of like we know lymph's there, but how many people really know the rate of fluid and where it gets back in? I thought it all got back in through this thoracic duct thing. Yeah, another correct. Yeah,
you've been living a lie all these years.
Because we've seen them tied off on numerous occasions, and if that's where all the fluid goes, the fluid gets back.
Yeah.
So lymph is the big out. Starling's forces out via the vessel, back in via the lymph, and interestingly, when asked, do the Starling forces still have an impact on the rate of lymphatic filtration and return, the answer is yes. So practically, even though the diagram's wrong for the geography of how the fluid gets back in, the way it gets back in is still in play. Just been joined by Tim Miller, who's the organiser of this meeting.
Good morning. How are you?
Morning. Very well, thank you.
Good. Great first day of POQI yesterday. I thought, what did you think? Good vibes, good discussion?
Yeah, excellent discussion. Obviously, it's always good to get a group of experts together. As Monty mentioned, some new concepts, new thoughts, and trying to clarify some ideas that have been in the literature for a long time. But I think for all of us that practice on a daily basis and clinically, it's great to revisit the physiology and see how we can apply the basic principles of the physiology to our daily practice, and that's what we're trying to achieve in this POQI.
You know, before you got here, we were talking about how we were just trying to distill down some of the terminology. And in our group, Tim and I, we're in the same group, Group A. And in our group, I felt like we spent a lot of time just trying to define terms and clinical or in relevance in a theoretical versus clinical kind of sense. And what did you feel like? Did you feel like we kind of came to a consensus on a lot of these terms, or still a lot of debate to be had today about that?
I think there's still more debate today, but I think we're getting towards consensus, and I think defining the terms is going to be very important. And I think we want to split it up into defining the physiology and the terminology, and then the clinical implications of that. And again, spending a bit more time thinking about the venous side of the circulation. We spent a lot of time going on various different terminology, stressed volume, unstressed volume, venous excess. But the idea that the venous circulation can be a pool with a part of that pool that is very much involved in preload, and some perhaps which is less involved in preload, and how we simply explain that in the manuscript, I think, is going to be our challenge.
I think the big overlap there from my perspective is the lymph and the venous side, because the destiny of the lymph we were discussing, in other words, if that's the route where almost all of the fluid gets back, not via every vessel out there, but into the lymphatics drain into the venous system. So we were told that although the sort of pressure the Starling forces apply, if your right-sided pressures are up, and this is where I think there'll be a big overlap, in other words, the right heart is straining or the venous system is overloaded in some way, then those lymphatic drainage starts to grind to a halt, and that's where you start to see the consequences of that.
But that's only the fluid that leaves the capillaries gets back that way.
Yeah, sorry, I should clarify that. You're absolutely right. The filtered fluid. But that filtered fluid comes into play as if you're getting your fluid balance not quite right. So in other words, if you've started to overload somebody with salt and water, the filtration rate goes up. If at the same time you've pushed up the venous pressure, the reabsorption rate can potentially go down. So that's where you're starting to create that edemogenic environment. And when you've forced a lot of it out, the other thing we're recognizing is the kinetics of the lymphatic return means you're looking at days, which I think we all know, we've seen that in the literature, days for that to fix itself. It's not a quick fix.
Exactly, and I thought it was very interesting how perhaps we could influence that, for instance, neuraxial blockade. There's not a huge amount of evidence there, but some tantalizing evidence that things like sympathetic blockade can really dramatically reduce that lymphatic return.
Yeah, when we were talking about that, that was kind of again, that clinical implication of, here we're at the bedside, and does the lymph really matter? And
if it's as described, if it's a muscular pumping system, the lymphatics that's dependent on sympathetic drive, if you block sympathetic drive, it's going to go down. And Dan Martin showed us a paper with some very compelling human images of lymphatic drainage before and after a sympathetic block. Usually, we don't hear much bad news, if this is bad news, about the impact of a sympathetic block that you might get from an epidural, for example. But this looked quite compelling, so I have to revisit the literature to see if there's anything in there that suggests the fact that might be clinically relevant or not. I don't know immediately. Do you think of anything? Any clinical? I mean, have you seen anything that makes you think, oh, I remember that patient now, I wonder if that's what was going on? It's not immediately...
It's not immediately obvious, but on the flip side as well, we're increasingly giving more, perhaps, norepinephrine or other inotropes and pressors, particularly with concern about hypotension, and Futier study and the work that comes out of the Cleveland Clinic. And could another effect of giving those drugs be that they increase the lymphatic return? I mean, I think we're going into research recommendations now. We don't have any clinical evidence, but it's definitely a very interesting concept.
Well, certainly hypothetically and demonstrated in laboratory models, again, work we were shown yesterday by Tom Woodcock Sr., is that if you give norepinephrine, your counterintuitively, perhaps, your transcapillary pressure goes down. So if you are worried about increased filtration rates, let's imagine early sepsis, and you're giving fluid to try and restore the circulation, and you're giving low-dose norepinephrine, which is quite fashionable now,
absolutely,
that would seem to make sense from the reduction of filtration with transcapillary pressures actually going down because of the arteriolar resistance going up. So downstream of where it causes the constriction, the pressure drops. And if it's acting on the lymphatics, the return is improved. So I've always been a bit wary about starting those norepinephrine too soon. But it does seem compelling from those first principles that if you've filled adequately, and we'll come back to that later, then a bit of norepinephrine is sensible, and that's probably why it's becoming very fashionable.
And when you've got studies like the FEAST study, for instance, that fluid or excess fluid could, any fluid could be potentially detrimental.
And FEAST was in children, sub-Saharan African children with sepsis and or advanced malaria, randomized to large volumes of fluid or less volumes of fluid, and the large volumes of fluid quite dramatically increased, very sadly, the mortality rate.
Correct.
Tim, I'm glad you joined us because you mentioned, and we mentioned stress versus unstressed volume, and we had a lot of discussion. I kind of felt like we were separated on intensivists versus anesthesia and some of the ways that we were using it. There was some confusion around that. What was your takeaway from the importance of that, and should we be including that in our discussion in the paper and the relevance of that?
I think, as always, there was more debate about the usefulness of the term. I think everyone agreed that the part of the venous system is more of a capacitance system and is sort of more of a lake where you can give fluid that's not actively involved in the venous return. It's just how you describe that, which terminology is useful. And some, I agree, some more of the intensivists preferred the term stressed volume. Other people were critical that it's not really a volume. So the term stress volume is actually quite hard to explain if you're trying to explain it to medical students, residents, even the rest of us in the room. That stress volume can make a relatively simple concept actually more complicated. So I think we need to include all the terms in the manuscript and maybe have a table of all the different terms. Even in one of our statements already, we've tried to clarify that stress volume actually may be a little bit more confusing in the fact that it's really relates to the pressure that you get and the inflection point in the venous system, at which point you get venous return.
Yeah. Something else. So the title of our group when we started out was the intravascular volume and fluid responsiveness. And we did end up talking a lot about venous capacitance after our conversation about stress versus unstress. So we actually kind of renamed, right, what our session was to fluid management and talking about venous capacitance and fluid responsiveness. So when we talked about intravascular volume, like how did we end up coming to terms with that and making that transition kind of to the new?
I think the discussion was whether the terms about thinking about how you define intravascular volume, whether that was actually useful. Because you can't measure intravascular volume. It's a variety of different methods, but they're all complicated and they can't be used at the bedside. What you can do is measure fluid responsiveness. And with regards to the venous system, we realized that, there is the Guyton's classic paper and there's some literature on the venous system, but there's far more on the arterial side. And related to the work we've already discussed on the lymph, that whether this paper would be useful if we focus a little bit more on the venous system and try to explain how the venous system works to practicing clinicians. And I think that could be a useful factor of this paper, rather than going through all the different definitions of intravascular volume, which are not terribly useful on a day-to-day basis.
So Tim, fluid responsiveness, our current understanding, could you give a bit more insight into that? What is fluid responsiveness?
So fluid responsiveness effectively is, at a core definition, is when you increase stroke volume by X amount, and I think that is debated, but in the goal-directed therapy literature is classically 10%. So you increase stroke volume in response to a fluid challenge. And that is the definition that I think we're going to come up with in the paper. The challenge, of course, sometimes when you're looking to see whether a patient is fluid responsive, is you don't always have a measure of stroke volume. You've got a patient in the operating room, you are doing goal-directed therapy using a device measuring stroke volume. You can give a fluid challenge to see whether a patient is fluid responsive. In the post-operative environment, frequently we don't have advanced monitoring. And you may want to do something like a passive leg raise. And again, we talk about passive leg raise as a surrogate for actually giving intravenous fluid, that you can lift the legs up and get an increase in venous return just from the legs itself. So you sort of auto-transfuse. And then if you're using a cardiac output monitor, you can see whether the stroke volume increases. If you're not, as typically on the post-operative ward, can you use blood pressure as a surrogate? And there are a couple of caveats, but generally I think if a patient is hypotensive and you lift the legs up and you get a significant increase in blood pressure, I think generally that can be used as a surrogate and probably can help clinical decision-making to give fluid.
So, offer a tip. I mean, I was part of the group that did NICE 174 guidelines, the UK guidelines for intraoperative fluid management, and at one stage we're going to include the use of a pulse oximeter. With a pulse oximeter commonly available, there's a plethysmographic component of it that gives, for many of them, an arterial waveform. And one of the things that I was taught early on, being sent out from ICU to go and evaluate patients at the bedside, is if you're nervous about giving fluid, if you put the pulse ox on the patient and you lie them flat, if they're happy to lie flat, as opposed to the heart failure patient who will not let you lie them flat, and the pulse oximeter signal gets stronger and the heart rate slows and the SATs get better, you're doing the right thing. And then if you add to that the leg raise or the head down tilt and things get even better, you can start to give that volume with confidence. And in our guidelines, we said for the very junior doctors, the nurse at the bedside, they can give repeated 250 to 500 ml boluses of an isotonic crystalloid. And providing with each one, things get better, they can do that up to a total of 2 litres. And when they get to the 2 litres and things, even if they're still getting better, they think they need more than 2 litres, they've got to phone an expert. And is it Henry? There you go. That's my. When you go to the bedside and you're nervous, the first time you're thinking, should I give them the fluid or not? That's my top tip. Any help?
Yeah, very helpful actually. Yeah.
Tim, do you think that's bonkers or do you think that's reasonable advice?
Yeah, I think that's reasonable advice. And we were talking about the passive leg raise. The concern is that, if a patient's in heart failure, the blood pressure can go up, but the stroke volume goes down. And of course, or if the patient's got abdominal compartment syndrome, and of course, all these scenarios can apply. But as you say,
the SATs won't get better, and the patient won't. The patient will say, "Doctor, I really don't like lying down. Can I sit up again, please? Because my heart's failing, and I've experienced this at home before, and I know what's happening."
Exactly. And let's face it, what happens generally is that someone just looks at the patient and says, give them fluid without doing any kind of dynamic assessment. So doing a dynamic assessment only gives you more information. If the patient feels better, the SATs go up, the heart rate slows a bit, you're more confident that fluid bolus is the right thing to do. And I think that's the important message.
Yeah, I think we have to stress that for sure in the paper.
Now, one caveat, if I may, before I hand back to the rest of you. I'm worried that the conclusion is going to be that if your heart rate and blood pressure is okay, that your volume status is okay. Because, I've harped on before about the fact that I've been involved in experiments where we bled 25% of our blood volume, and with 25% of your blood volume in the bucket, you can have a normal heart rate and blood pressure. And Dave McLeod's in your group, I think. I don't know if Dave's spoken out about this yet, but he's done some of the most recent human hemorrhage studies. And I think everyone, if they haven't yet, should look at his results to turn around and say, well, hang on a second. You want a patient's... It's different, when they establish critical illness. It's different when they're under anaesthetic. But that patient on the floor, you can make their blood pressure go back to normal. They can still be 30 or 40% short of the mark. So I think people must discuss that this morning if they haven't already.
Agree. The focus of the paper more is on fluid responsiveness, but I completely agree with you. I don't think we're ever specifically saying that if you've got a normal blood pressure, you've always got a normal stroke volume.
Exactly, but the question I hope will mature to the point that once you're not fluid responsive, on a balance of probabilities, are you probably adequately full? And I think that Dave would be able to share with you, as we could share with you, that the stroke volume does go down as soon as you hemorrhage those individuals. So if you do have a method of determining, in other words, by creating fluid responsiveness with the first 250 ml hemorrhage, if I'm making sense there, it does happen. So in other words, the flip of that is, with as much confidence as you can have, it would seem that you could say that a patient is adequately full if they are not fluid responsive. There's always going to be caveats, but do you think we'll get to that point today?
Yeah, I think we have said that. We've said that if a patient is fluid responsive, they are, by definition, hypovolemic. And if they are not fluid responsive, I think you can, with a reasonable amount of confidence, say that they are intravascularly full.
But the counter-argument would be, as we sit here at the moment, we're fluid responsive. Because that's part of being an exercising human, isn't it?
Yeah. We've had that discussion as well, and I'm sure we'll continue this morning. So, all right. Final thoughts about yesterday?
Well, just before we move on there, I just wanted to gauge what is POQI and why is it so important? Why are we doing this? Tim, have you got any comments on that?
So POQI is the Perioperative Quality Initiative. It's in its third year now, so this is POQI 5. And really... Sorry?
No, I was just celebrating POQI 5 because we couldn't remember it.
yeah. Oh, yeah. This is POQI 5. POQI 6 is coming in the later this year. And it's really about getting a group of experts together and choosing topics that we feel that a group of experts can add to the literature, and having these 2-day conferences this modified Delphi approach to really put a practical manuscript out there that we think can help practicing clinicians be aware of the latest evidence, but also the practical implications of that evidence, how they can apply it to their patients on a daily basis. It's a very exciting thing to be involved in. I think the manuscripts that we've produced have been excellent, and hopefully it will continue.
It's a QI, it's a quality initiative, and that's the bit we must always loop back to. So at the end of today, if we can't give some guidance that helps people go home and see if they can improve the quality of the care of their patients, we've fundamentally failed. So hopefully we'll be celebrating the end of today with some very, very clear, pragmatic messages. Have you found it helpful, Henry?
Yeah, definitely helpful. I think it's a great opportunity to come out with recommendations into how we change practice tomorrow and how we can improve our patient outcome. And fluid physiology, such an important topic, and it's important to understand and make sure everyone who we target understands this. Is medical students, doctors, nurses, everyone should have a sort of brief understanding, and this is a way to portray this to everyone.
It's good, and I like the emphasis on quality initiative. I think that may be a good thing to reinforce to the groups, maybe first thing this morning, because as I mentioned, that is key. We're here to try and improve patient care by, in this particular POQI, better understanding of fluid physiology.
And Desiree, in your role, it's nice to know the clever stuff so you can understand what you're doing might be helpful, but at the end of the day, you need to know what to do that might help.
Yeah, and it does get so easy to get into the weeds whenever we are in there, and everyone's hotly debating some of these topics. But it's always nice to take a step back. And Tim, you did this really well yesterday. It's like, okay, but how is that really gonna? How are we really gonna use this? And I think we need to continue. You need to continue to do that to really make sense of it. And I
think it's a challenge because sometimes you do need to get into the weeds. You need to go into the weeds to get to a conclusion, but equally sometimes you can get lost in the weeds.
The clever stuff yesterday morning for me helped me a lot to hope to be able to go and make some more practical clinical recommendations about how you might, we're always trying to avoid salt and water overload, but once you've got it, what circumstances do you need to give the patient the best possible chance of getting it out? Yeah. I learnt a lot from that, and I needed to do the clever stuff.
And it's the process of it that's really unique and great, and that makes it what it is. So,
but we needed to do the clever stuff, and now it's getting that clever message to the readers in a simple way that then they can read that and then go back to the practical recommendations and understand, in a way, the journey that we've been through. And that's going to be our challenge.
Bingo.
So, Henry, it's all over to you now, buddy. Okay. So, this evening, we're looking forward to recording Henry's big takeaways.
A new series. Part of our series.
Horrible Henry.
All right. Well, let's wrap things up. I think we're going to get started here shortly and finish out the day, round out the day with some great recommendations. That's our hope. So we will be back later with hopefully some wrap up and talking about what we heard and what we're going to be recommending. So thanks again for joining us on our series, Fluid Matters, here at Duke, at the Washington Duke Perioperative Quality Initiative Consensus Gathering.
Top Med Talk.